Once again, this webinar will be recorded and the recording will be sent via email. And now I will introduce you to Dr. Margaret Mead, who will help to moderate the webinar and assist the panelists with any questions or comments. Dr. Michelle Mead is a professor in the University of Michigan's Department of Physical Medicine and Rehabilitation and Family Medicine. She is also the director of the IDEAL RRTC. Dr. Mead, the floor is yours.
Thank you very much. I am delighted to be able to welcome everyone to this excited and interactive webinar about exploring the intersections of person and place, healthy aging for adults with long-term physical disabilities. This webinar will be an interactive, dynamic conversation between interdisciplinary experts, including those with lived experience, exploring topics related to healthy aging for people with long-term physical disabilities. The importance of environmental factors, including built, attitudinal, and policy environments, will be highlighted, as will high priority concerns of folks aging with disabilities, including issues of housing, social determinants of health, social disconnectedness and isolation, and home and community-based supports. Experts will also discuss the steps they feel that individuals and communities should take to enhance outcomes. We welcome once again your questions, and I am delighted to start by introducing you to the panelists who are here. As mentioned, my name is Michelle Mead. I am the director of the IDEAL RRTC, which is supported by a grant from NIDLR within the Administration on Community Living. Also in attendance is Dr. Philippa Clark. Dr. Clark is a professor in the Department of Epidemiology at the University of Michigan School of Public Health, as well as being a research professor in the U of M Institute of Social Research. Ms. Robin Rontel is also joining us. She is a co-director of the IDEAL RRTC and leads the data analytics and consulting projects for the Center for Health Research and Transformation at the University of Michigan. And we are also very fortunate to have Dr. James Krause as a panelist today. Dr. Krause is the Associate Dean for Research and a professor in the College of Health Professions at the Medical University of South Carolina in Charleston. He is also the director of MUSC's Center for Rehabilitation Research in Neurological Condition and leads a team of investigators on health employment and longevity project for people with neurological conditions. Joining in fact, we are fortunate that she was able to join, is Dr. Margaret Campbell. Dr. Campbell is the owner of Campbell and Associates Consulting in Seattle, Washington, where she focuses on bridging aging and disability research and policy, as well as facilitating the adaptation and translation of evidence-based interventions to community settings to improve health and well-being outcomes. Dr. Campbell will be serving as the facilitator for today's discussion, both sharing her own expertise and helping to put together the questions for myself and the other panelists. Dr. Campbell, are you ready to start?
I am.
Fantastic. So just a quick acknowledgements. Once again, we'd like to thank NIDLR and the Administration on Community Living for their support of both the IDEAL RRTC as well as for other projects, especially those funding Dr. Krause. And just let you know that this is the general flow of questions and topics that we'll be going over during today's discussion.
Thank you. Thank you, Michelle. Hello, everyone, and greetings. My apologies for being late. The internet was out in my whole community, so I'm in a different community. I am very delighted and honored to serve as your facilitator today, and thank you, Michelle, and your team for inviting me. It gives me a wonderful opportunity to work with former colleagues and to work on an area that we all care passionately about. Just a quick remark before we get started, a personal remark. as I see it, what we're all trying to do with our work and with this conversation, the overall goal is to advance understanding of this important topic of aging with disability. And it's in doing so, to encourage and motivate research, but also inform policy and practice, and all focused on how to improve the lives of people aging with disability. So let me just say that if we have time at the end of the discussion, you can submit questions yourself. You can use the Q&A function at the bottom of your screen to submit your question, and I will be monitoring that. It's on your Zoom window, the bottom of your screen. And if that doesn't work for you, you can also give an audio question by clicking raise your hand. You see a hand at the bottom of your screen. You can click on that, and you can introduce and present your question in audio format if we have time at the end. So without any further ado, we're going to start the questions, and we're going to start with some foundational questions that the panel's interest, but also some of your input. So to get us started, the very big question, and the perfect place to start, is how do we define aging with disability? What do we mean by it, and who does it include? And I think we're going to start with Michelle on this one.
Thanks, Margaret. I guess I take this two ways. I think about people who have been living with a long-term disability. So the aging process begins at birth and goes throughout the lifetime. So there's an aging process that an 18-year-old could have been going through as they've been living their whole life with cerebral palsy or another type of physical disability. But what we often think about is older adults who have been living with disability for a significant period of time, whether that's 2 or 5 or 10 years, and have experienced the additional accumulation of stressors during that time. And I think I'm going to move that over to Jim, because his experience and discussion about this is going to be maybe a little bit different than my perspective.
Good. Jim's probably been doing research in this area longer than any of us. So go, Jim, go for it.
That makes me sound so old. Actually, for people who are not familiar with our research, I was very fortunate that I connected early as a graduate student with Dr. Nancy Crew, who was one of the people that are most responsible for the field of rehabilitation psychology and actually rehabilitation practice. And Nancy had started a study in 1973 of people with spinal cord injury, and I was able to join that study as a graduate student. And 1984, and we've been able to do follow-ups every 5 years since. So when I think of aging with a disability, I'll think of it from a personal perspective as well as professional perspective, because my own injury was 50 years ago. And I think there are differences, between people, as my friend Rod Adkins would always say, study of aging with disability is not the study of the aged with disability. So we have things happen, whether we are injured at 16 or have a disability onset at that point in life or later. We're always aging with a disability once that disability happens. And so I would see aging as a developmental process. It's not necessarily aging as you get to a certain level, but aging throughout the life cycle. We're going to talk a little bit today, and I'll make my note now and not say it so much later, but when we talk about disparities in general, and we talk a lot about race, ethnicity, and poverty and different characteristics, disability is one of those groups. We have people with physical disabilities face discrimination and barriers and things that we need to work through. And we do as a matter of aging as people get to certain levels. So I think that that's the underlay of what we need to consider, is what do we face as we age, different points in the developmental process.
Thank you, Jim, and thank you. Anybody else on the panel want to comment on that? I think that lays the groundwork very nice.
And I may ask Philippa, because it may go into that, in terms of the life course perspective and what
Yes.
is the intersection and overlay of that.
Right, we're going to actually turn to that sort of now. All of us here on the panel see this aging with disability as the intersection of the study of aging and gerontology on the one hand, and with rehabilitation, research and practice, and disability research on the other hand. So it really is this intersection, and it's a very rich, exciting intersection. And we use this phrase, aging with disability, and I think so many people need to better understand not only what we're referring to, but who we're referring to. So who are the target populations when you think of aging with disability, regardless of the age of onset, as Michelle and Jim have pointed out? The age of onset can range from birth. In my own mind, I think of it ranging from birth up until really late middle age. All those folks are really aging with disability. But who are they? Who do we think of? Who would like to comment on that? Who are the target populations?
I can certainly comment, and I would like to also raise another issue. I think historically, maybe in the past 10 years or so, there was some tension between thinking about the population aging with disability and those aging into disability, and seen as two separate groups. And I think, Margaret, you've been really leading the forefront of trying to integrate that discussion that, as Jim says, aging with disability is a process that happens across the life course. But I do think it's important from my own perspective to understand when a disability happens in that life course process and how that could shape future opportunities, how there's a cascading sequence of events that could happen or not happen due to the time of onset of a disability. People who have a spinal cord injury earlier in life may experience more challenges in accessing employment. People with multiple sclerosis as well have the same challenges in accessing employment and healthcare access in ways that people who are experiencing a disability much later in life don't necessarily have to navigate earlier on. At the same time, people who have experienced a disability earlier in life have an ability to adapt and think about ways to cope and manage and find alternatives in a way that people who experience a disability much later in life might not have that arsenal of coping and adaptive strategies. So those are my 2 cents on that topic.
I think that's very important. I think so. Timing of onset is what we're pointing out here. The timing of onset in the life course and how that shapes the disability experience, because it does shape the disability experience. I think I would add just real quickly that people who have later onset in middle age, it's frequently the result of the cumulative effect of chronic conditions that were not properly treated, or there have been exacerbations, so that it can be a different cause of disability too. Instead of neurological, it can be more neuromuscular or muscular. I see your hand up, Michelle. Is it time?
No, I was just going to say the issue with regard to not just where it fits into the life course, but also the resources that when you have, when a disability onset occurs, how it affects resource accumulation. And so as we talk about the associations with social determinants of health and a bidirectional relationship, we're really thinking about individuals who obtain or acquire a disability earlier in life often do not have the same opportunities. They have lower rates of employment. They have lower rates of marital. There are more issues in terms of participating in the environment. Not that it can't happen, but it's often harder because of the environmental factors and the attitudinal barriers that we talk about. And so there's often then an accumulated disadvantage that comes with living with a disability in terms of less accumulated wealth later in life, less pensions, less retirement benefits, less social support that may be there. It's not necessarily there, but recognizing that disability is often associated with poverty. And this is one of the factors that we have to explicitly be aware of and address. And it's not just that individuals with disabilities who are poor have better outcomes. It's that disability itself, because of the way our healthcare and social systems are structured, result in disadvantage and low income and poverty and associated negative outcomes.
Right. Yes, just to sum up a little bit, we'd all agree with that. So I think we're getting to later in our questioning because we're getting to the intersectionality. Aging with disability doesn't exist in a vacuum. You have to take all these factors into consideration: the timing of onset in life course, the nature of the disability, the social environment, the social and economic environment. So all of these intersectionality that we need to look at. And a lot of those factors produce some of the disparities that Jim was talking about, the disparities due to disability.
Can I just add one other point before we move on to the next area of focus? I think it's also important with timing to consider that intersection with whether a person is employed with benefits that support them in disability, whether they have a disability that meets the criteria for Social Security disability coverage, if they are, if it's a congenital disability, whether that also has certain special coverages from an insurance perspective, because this factors into predicting whether a person is going to be able to access those resources that are so critical to prevent the compounding of effects that result in more rapid health decline and associated issues that create or exacerbate situations of poverty and poor health.
Very true, very true. And I think we need to...
Right. So actually, Jim wants to add to that a little bit.
Sorry, go ahead. I saw your hand now. I didn't see the yellow flag.
I would just like to say it's different, younger to older at onset. So we always tend to think of things as better or worse, but in reality, they're different. They come with their benefits. And as Michelle said, you economically, you may be better if your disability onset is later in life, but when it happens early in life, you have a chance to develop a whole network of people and activities that are among people or familiar with disabilities. So it marks more of an opportunity, but again, there are also things that are worse. So I would encourage people, as we talk about aging or disability, any of these things, not to think so much better or worse than to think different.
Good point. Very good point.
Mm-hmm.
And I think one thing I'm just going to mention very quickly that confounds it all is what historical period in which you encountered your disability, because people, younger folks who have grown up in school systems and whatnot, where there were disability benefits and programs and laws, had a very different experience than older folks whose disability was earlier in history, earlier in time, and not just earlier in the life course. Okay, I think we should move on. How about that? I think we've hit about our 10 minutes allocated for the whole broad construct of aging with disability. Who does it include, et cetera? So let's shift to healthy aging, because that was one of the areas of focus for disability.
And I think, Margaret, I'm not sure if you saw the most recent version of it, in which we were thinking about aging for about 20 and then healthy aging for 20 and then the last 10. And so I guess I want to just then step back a little bit to that life course perspective and what the aging process is. And I wanted to go back to Philippa for that, from someone who does work in the aging field more specifically. When you think about expectations associated with aging, when you think about that life course perspective, what issues come up for you? And this may be what you said before about when it occurs or the different opportunities, but in general.
I think in terms of expectations, so I'm a gerontologist by training, and I grew up with a mother who had multiple sclerosis. And I think that there's a sense that expectations are going to be always changing. and that it's not always possible to anticipate what the future will hold. I know my mother was forced to retire earlier than expected, which had consequences for her retirement income. So I think there's a sense of uncertainty that is part of the process of aging with a disability, regardless of when it's the time of onset. I think as Michelle said, earlier onset does result, I think, in cumulative inequality in terms of potentially differences in educational attainment and employment. But I think I do think that there's a general common feeling that there's an uncertainty and a need to be adaptive and to expect change happening in a way that I think people aging without a disability don't have to address to the same sense of urgency.
Is that, would you say, Philippa, that's why we talk about this idea of accelerated aging for people who are in middle age, for example, but who've had long-term or lifelong disabilities, that there's kind of this sense of accelerated aging? Go ahead, Michelle.
I would actually say some of that is actually on the body level, that we know that folks living with chronic conditions and physical disability, as well as sensory disabilities, experience onset of chronic conditions, whether it's depression or Alzheimer's disease or diabetes or cardiometabolic or musculoskeletal, both earlier and at a higher rate than individuals matched controls without disabilities. And that those from more low income populations have the highest level. And so there's, what occurs at the physical body, I think, whether it's as a result of the stress, physical and mental, that goes on, whether it results from the differential ability to engage in health behaviors in a positive way, whether because of individual choices or the environment or the combination of that, the individual is then living with more negative consequences, more things that are affecting their body's ability to cope, their body's ability to function, to fight immune, to have a healthy immune system and to fight the various diseases or conditions that go. I think about it in terms of a lot of, when I talk about things, as the margin of health gets narrower as you age with disability. You can do things to healthy behavior structures to create more room there, but that the longer you age with a disability, the more any one condition results in a cascade of events. Jim, you had your hand up, and then Robin.
Yeah.
So I think that we need to realize that what people do is probably going to be more important than a lot of the characteristics we talk about. We talk about demographic or social characteristics. Individuals have a great amount of control over their outcomes. And so we see wide differences in risk behaviors, what people do and what they can do to keep themselves healthy. So as people age with a disability, a lot of them don't make it if they end up having very risky behaviors. But the other flip side of that, as people get older who have been very successful in maintaining their own health, there is this accumulation of decline in their body systems, and they may be unprepared for the changes that will come as they age with a disability. So there may be added needs, there may be a decline in ADLs, ability to do ADLs, those things happen. And so if people are not prepared for it, if someone, for instance, is an independent wheelchair user and can do all their own care, and all of a sudden they're really not able to do that in the same way, then the decline can become rapid and they can get into critical situations of what we label negative health spirals, which are simply the onset of one recovery course for a condition, something else develops during that time, then something else develops during that time. So the original condition may be gone, such as a pressure ulcer, for instance, but there may have been an infection, there may be loss of independence, even amputation or life-threatening. So there are different challenges for people with healthier behaviors versus not.
Good point. Yes, Robin, I think you were
Yes,
next.
I wanted to say that I agree with both Jim and Michelle and Philippa's comments related to this, but I wanted to offer a counter thought, and that is that assumptions are made often by the medical profession, employers, or others that work with individuals with disabilities, that they are going to either have limitations or not be able to do things that ordinary, quote, people can do, such as reproductive health, or wanting to be fully engaged in a work setting with accommodations. And in spite of likely having exacerbation and earlier onset of some of these aging type conditions, there needs to be a respect for their desires and ability to be fully active and engaged as long as possible.
So are you saying that the attitudinal environment, particularly the attitude of healthcare providers and what their assumptions are about quality of life or about living with a physical disability really impacts the opportunities and the outcomes?
Yes, exactly.
I think, Philippa, you wanted to chime in on this area.
Yeah, I was just kind of wanting to respond to the issue around maintaining health behaviors, and just to point out that the ability to engage in health behaviors is often not just an individual's decision, but it's a function of the constraints or the resources in the environment. Not only, I have a lot to say about this, so let me just break it into two parts. One is the social supports that people have, their caregivers. Many people aging with disability talk about the fact that their spouse or their partner is their main caregiver, and that caregiver is also aging, and they know that that's actually a risk for them down in the future, regardless of their own health. And secondly, beyond social supports, we know that the factors in the built environment are so important for allowing people to continue to be able to engage outside, to be active, to interact with people, to access healthcare. Simple things like paved surfaces and curb cuts and ramps and elevators and a lack of gravel surfaces, can make an enormous difference on whether someone can just get out and be mobile in their community. Are there sidewalks in place? For those of us who live in Michigan, winter weather is an enormous barrier for any kind of activity and engagement. And for people who have the financial resources, they'll go to Florida, but most people don't have those resources and that ability to do that. So I think it's important to consider the situation in which we live in a context.
I think we're just about ready. Robin, do you still have a question? Your hand is up. Okay, that's all right. Before we go into the next section, I think just one of the questions we had is, why is this whole topic of aging with disability important to the field of gerontology and to the field of rehabilitation and disability? Why is it important? And I think just to try to sum up, we could talk about that for a long time, but I think when we talk about the life course perspective, as Michelle keeps iterating, we need not to have this truncation where we start aging by all our databases, all our national surveys start at either age 50 or age 65. And then we have this truncation or bifurcation, and we don't look at how people are aging into 65 and later. What are their characteristics? What are their ability and impairment status? So we have this bifurcation that I think with aging with disability, we are really trying to bridge it, bridge both aging and disability fields and get a better understanding of this growing population. I think we all know the population aging with and aging into disability is growing for a lot of factors. On one hand, it's the higher rates of obesity that contribute to diabetes and that sequela. And there are other, and we're living longer. Obviously, we're living longer. So with all that context, thank you all. Let's talk about healthy aging with disability. But first is when we say healthy aging, how is it defined? How is that defined in the literature from your various perspectives? Who wants to start with this?
And I guess the literature seems to really agree that successful, healthy aging is associated often with a sense of independence, purpose of life, and quality of life. I think the issue of independence is becoming increasingly questioned, and if that's really as important as a sense of interdependence. But I think the sense of purpose in life is what we hear across cultures. It doesn't necessarily mean I don't have an impairment, I'm not sick, or I don't get chronic conditions, but it means I am connected, I have a value. However that is defined for the individual and the culture is of primary importance.
Who else would like to chime in on this concept? It's been a controversial concept, hasn't it? Looked at from the perspective of disability. It's been a very controversial. Others have written on this, like Ivan Moulton has come up with a kind of a different model for successful aging with disability because it's been so controversial. Anybody else want to comment or say anything on that? So I think you said you gave us a good start there, Michelle. So when we talk about healthy aging, I would just add one thing from the vast literature on the self-reported. There's a famous question we ask in all our surveys: individuals' self-reported sense of physical health. We still face this fact that people with disabilities are far more likely to report their health as poor or fair than people without disabilities. This is what we're up against. We have to move that needle because the perceived health status of people with disabilities is much lower than people without disabilities. So then we have to look to social determinants. So I think we're ready to kind of start talking about social determinants, aren't we? And how they impact healthy aging with a disability.
I think yes, but I'm also hearing the health and health outcomes for me has that large intersection with the healthcare system. And once again, how individuals with disabilities, how older adults are treated by the healthcare system, how much value is put on their lives and their narrative, what they say, how care is adapted or not based on their needs. As was previously mentioned, too often there is the perception by healthcare providers and even physiatrists that individuals with disabilities don't have as good of a quality of life, that they're not sexual beings, that they're not going to be living independently. And so they don't bother to ask, they don't bother to put in the supports or make sure there's the resources or programs to support the lives that that individual wants. And I guess the other piece of that is there's still patriarchal models, which says, well, living with healthy with a disability means doing what I say in terms of managing your health, rather than to once again figuring out one's priorities and the best choices given the combination of personal and environmental factors and priorities that exist.
But wouldn't you say though that the healthcare system is part of the determinants of health? Isn't that part of the social determinants of health?
Oh, completely. I mean, and it's not a static system. And
Right.
you have both the structural components of it and the policies that are created there, as well as individual providers that bring in their own biases and knowledge about working with people and with their knowledge about specific consideration and making adaptations based on either impairment or diagnosis.
Everybody, this is such a rich conversation, so I'm going to move us forward a little bit, but before we do that, I'm going to ask if someone would provide kind of an overview of when we say social determinants of healthy aging with disability, just to identify the factors that are included in social determinants. We're not going to be able to do an exhaustive conversation, but would somebody take the lead on that and just kind of mapping out what are the factors we think about in social determinants? No, nobody.
I think Philippa was going to jump in.
Okay, Philippa, please.
Yeah, so social determinants of health is something that's getting a lot of attention now, but it's a very long-term construct that's existed in the public health literature for decades, even longer than, I'd say 50 years. It's thinking about the upstream determinants of health. So not just what you do in terms of your health behaviors or whether you avoid smoking, but the social factors that would predispose someone to smoke, for example, in terms of prior family history of smoking, being in a circle of friends who smokes, being educated, enough education or receiving information about that, being able to access healthy food in your neighborhood, what other things, being able to access transportation. I think it's all those things that we think about that are not really the responsibility of the person, but the things that the person is in fact downstream from that shape their behaviors and their actions.
And their opportunities. I think that's the other piece.
And all these factors, this could take us into a conversation about policy, because social determinants are really, in many cases, under the control of policy, right?
Well, and I think it does need to take us. And I think that's, I want to hear from Robin in terms of more of that policy component.
Robin, you have the floor.
Thank you. Yes, I mean, this is where policy can help or harm or speed up or slow down progress, because all these issues that Philippa mentioned take resources and a focus on either finding ways to avoid the issue in the first place, or resolve it early in the process before it becomes a significant problem. The person starts smoking. If something can stop it from starting, that's the best policy solution of all. We have been studying, for the most part, the population that is duly eligible for Medicare and Medicaid, which is predominantly individuals with disabilities and very highly vulnerable population, where you have that intersection of disability and poverty. And this is where a lot of the social determinants of health are both apparent, and some of the studies have been focused on ways to improve people's lives and situations and health, given all these compounding factors. We had a debate in this panelist group about whether social determinants of health were the cart or the horse. And we actually decided that they're both, because there are many situations you can point to where a person might grow up in poverty with lack of access to good nutrition, housing that doesn't have, that's not accessible for individuals with disability, and many other factors that tie to social determinants of health. But you can also have someone who is an individual with disability, and social determinants of health begin to impact them when they can't find employment, when their housing situation goes bad, when they ease into a poverty situation when they weren't previously in that situation. So there really is both dynamics going on here. And I know we'll talk about this further, but I want to just say now that there are some things that give me hope, because we're in our work right now on the dual Medicare and Medicaid eligibles. There have just recently been some policy changes that CMS is putting in place based on learnings from the programs that they've had for dual demo areas of focus, some of the waiver programs. They're taking lessons learned and turning them into requirements for these types of programs. As an example, it's going to include a requirement that the health plans that provide services to dual eligibles are going to be required to have advisory boards with enrollees and also those with lived experience as part of their requirement to do business with CMS. There are also going to be other things like that that are being put in place based on lessons learned. I'll stop there.
So in my role of moderator, we're again, we could spend, this should be a series. This should be a series, not a one-time webinar. This should be a series. Just as this is the overview. So we want to get to what the research is telling us so far and where the gaps are and where the gaps are that we really need to address. But we've got a question from a response from an audience that I want to interject here. We haven't listed aging in place, and that that used to be a construct that was just pertained to the gerontology world and to older adults. But again, it encompasses multiple target populations, including aging with disability. So who would like to talk about some of the challenges that may be different for people who are aging with disabilities, physical disabilities or other kinds, in terms of the aging in place notion?
I think this really applies. Jim and then Philippa and her expertise with the built environment, both are going to have really good insight here. Jim, did you want to start? Whether I know you wanted to talk about something else first and then shift into the aging in place.
Well, my mind is still 5 minutes ago. So the way it works, I'm going to have to talk about that. But when we talk about social determinants and policy determinants, and I'm thinking about there are policies that lock people with disabilities into poverty because they don't allow people to work. If you work, there are some programs, I'm not a policy expert or a program expert, but there are people that have legitimate fears they will lose their benefits, all their benefits, if they are employed at all. Their spend downs, they lock people into poverty. And I would say the circumstances are different by diagnosis. So Philippa, you talked about your mom with MS. The model with employment that we see with MS is different than, say, a traumatic onset, where MS is somebody's trying to hold on. They've got that job and they're getting, they're seeing symptoms and they're trying to hold on to it. Once they lose their job, they're kind of done. They're rarely going to go through retraining. That's very different. And that's a policy issue. That's, that is vocational rehabilitation, going to reach that group. But the same with traumatic disability being different, because everybody knows when a trauma has happened. People lose that employment and go back. And the employment and the poverty absolutely linked to the health outcomes. It's a primary driver, not just of health by virtue of access to resources, by access to social environments and friendship patterns and all those things that are fundamental. So I'll let somebody else answer the second question.
So the aging in place, Philippa, you want to start there? And I may have a few things to add.
Sure, I'd be happy to. I just want to, I'll draw on some of the recent research we just finished conducting with a group of people who are aging with a physical disability. And we conducted both, a survey with them, but also qualitative interviews. And they were so informative. And I'm going to share some of their responses and the ideas that they shared with us, because it talks about the importance of being able to age in place, the importance of having accessible housing, but recognizing also that aging is very, very hard on the body when you have a disability, and that you're going to age a little bit harder with a disability than you would without. And that the responses were so focused on the need to maintain their function for as long as possible and being able to exercise and be physically active. But those things were really, really constrained by often just the environment that people are living in, not only the community, but their houses, and whether or not they were able to actually get, they had wide enough doorways for wheelchairs to pass, whether they could actually have other people continue to come and visit with them in their home, because if they had, steps at the entry. So I think thinking about housing structure, community structure, but also just resources in the home in terms of adaptive equipment is so important. Whether or not there caregivers as well that can help. But I think also this thing that came up repeatedly was a recognition that things were going to change. No matter whatever they got set up in their homes, that they knew things were going to change again, and they had to anticipate further declines or changing conditions or additional infections or a change in their caregiver status that was going to cause them to need to adapt. And I think that's part of what it means to be aging in place with a disability.
And I think I'd love to build on that, because I think this is one of the areas both of that we need to examine and promote more, and that it can be harder. And so change requires cognitive flexibility, both of you and the people around you. You have to do things in new ways. You have to learn new ways of getting around, new ways of moving, new ways of interacting, new ways of setting up your house or getting in and out of those. It develops specific attention to new behaviors and new patterns. I think it's important to recognize then that the onset of aging or the aging process for individuals with disability may bring on that unexpected functional decline. Often when we think about spinal cord injury, it's like, okay, I have a sharp decline at time of injury, but then it increases and evens out. What we're talking about with aging is then it begins to go down again. And that adaptation process has to happen again. And you have to rethink about how you're moving about your community. If you're now using a power chair versus a manual wheelchair, if you're no longer throwing yourself in and out of bed, if you have to change your environmental spaces to get into your bathroom or use that in a new way, if you have to think about no longer being able to drink soda because you now have diabetes, which increases the risk. If you're, you have to suddenly think about different things, and the ability to do that and to make those changes, not in your own behaviors, as well as possibly your environment, is going to be critical. I remember one of the, I'm sorry.
Jill, because we have 7 minutes left or 8 minutes left, and we have a couple of questions from attendees, and one we're going to have to type the answer, but we have another one about databases. And let me bring this up because we're starting to talk about research a little bit. And this question is about research. The person says, thank you for the wonderful discussion today. I am wondering if there are any public data that could
lots and lots. Sorry.
Let's hear the question. That can compare the aging trajectories of people with long-term disabilities, people with short-term disabilities, and people without disabilities. I'm going to make one quick comment before people respond. One of the problems with this bifurcation between gerontology and disability is that we have very few national databases that go across the age span. For example, they either start at age 50 or start at age 65, or their general population, but don't do enough on disability. So with that context, there is the NHATS, and maybe somebody can talk about the NHATS. Anyway, so they want to know about public databases that will allow you to make these comparisons of trajectories for different ages of onset, people with physical disabilities. So Michelle, is that you, or is that you, Philippa, or is that Jim? Who wants to?
I think you've got within the ICPSR website, you have the Center for National Databases or Rehabilitation Databases. And through that, and I forget the exact acronym, it used to be through UTMB, and it's now the collaboration between a variety of sources, that you have all of the public databases available. You have what are the variables they have and what are the people included. In our research, we're using a lot of insurance data sets and then linking it to other ones through NANDA, through other publicly accessible ones. But I will try and get the specific website for the center at UTMB, and which is a great starting place.
That's a very good idea. It's a very good idea. Anybody else want to comment on that question?
I just want to comment quickly in that I think part of the problem is that we don't have databases that span the life course, but I think an additional problem is we don't have good questions that ask about disability.
Absolutely. We don't ask age of onset. We don't ask age of onset in any meaningful way. We say, just have you had the disability for 6 months or longer? And that's it. Okay.
So, Margaret, I have to point out the issue with existing data is it's not designed to answer your question. So it's look at existing data, you're doing it, you're sort of data in search of hypothesis, in the sense that you're going to have to try to secondarily fit to what your research questions are. And with regards to disability, a lot of what you'll see, there's a lot of value in looking at national data on limited questions, but they lump everybody with disability together. I don't even mean that not having diagnoses like SCI and MS and stroke. I mean, stroke there. I mean, there's
Right.
they're very, very broad categories. That's all I would say.
We have just literally, we have 4 minutes. So I'm going to switch to the last section, and we have a choice real quickly. Do you want to talk about what each of you, what you think is the most critical research area that needs to be pursued? And that's really tied into the future. What are the biggest gaps? I'm going to go through each panelist, and you have very short time. And we're going to start with you, Robin. What are the most critical research areas?
From a policy perspective, areas that can examine the evidence of the outcomes of policy changes that are on a small scale that could be enlarged to a national scale. And these are, I would say, number one, home and community-based services to allow people to stay in their homes.
Perfect. Thank you. We're going to go next to you, Felipa.
I think the biggest challenge is data, and that we don't have data that collects information about aging with disability. I think that's our biggest problem.
Okay, Jim?
Ooh, I would say the need to understand the critical points for people who have aged well, that the critical issues when things fall apart, those things when things fall apart. And I would also say research that helps us to understand the limitations of a rehabilitative model when we're talking about aging with disability, and the need to have a public health model where we can identify what's happening to people in real time, things like surveillance, where there's surveillance where they know and can identify in real time somebody's been in the emergency department, they have a diagnosis of, I'll use spinal cord injury. How can we get resources and intervention information to those folks? Because people get lost. The longer you've had a disability, you get lost. None of that stuff you were taught a long time ago, not much applies, or applies directly in the way it was taught.
Thank you. I'm taking notes on all this. Michelle, as the director of the center, we give you the last word.
Thank you. I think for me, a lot of it comes down to the attitudinal environment. Even questioning that individuals with disability, living, aging with disability, can and should have a good quality of life. And that is not just the responsibility of the individual, that there are structural factors that have to be recognized, identified, and addressed to allow that to happen. That it's hard enough living with a disability. You shouldn't always be the one trying to do more, trying to develop resilience, trying to be as healthy as possible, that we also have to develop the systems that allow that to happen as well, and to connect these and tailor these approaches.
So we are 1 minute by my clock, 1 minute from our closing time. I would just like to make a pitch to Michelle and her center that you continue this and that we select something a little more focused, or that you select something a little more focused, because there's so much interest in this area, and we've just scratched the surface. But thank you for allowing me to participate. Michelle, why don't you the closing
Right.
number?
I was going to say we have a couple things, 2 more things we wanted to share today. As note, we will be sending out the other resources related to it. If you want to find resources or programs in your area, the RRTC has developed a National Resource Center for Aging with Disability that has information about programs across the United States, as well about the policies that affect them. And so please go on there and check out how to use it. We also have our phone number that an email that is regularly staffed and can respond to questions. Please save the date for 2 upcoming webinars. One is on NANDA. You want to talk about a wonderful place to find information about other data sets in neighborhoods and how they can interact. Considering attending that one by Dr. Clark on July 27th. And then the next webinar in this series on transportation and autonomous vehicles by Dr. Clive D'Souza in October.
Thank you, everybody who was participated via Zoom. Thank you very much. In a rich conversation. Michelle, last word. Anybody on the panel, last word?
I thank you all. Just as I would agree with Margaret, we want to keep continuing. We want to keep pushing. We want to bring the policymakers into this as well, and policymakers at all levels, whether it's policies that makers at healthcare providers, in cities or federally.
Wonderful. Thank you. Thank you all. Thank you, panelists. Great job. Great job. Bye-bye.
Bye.